for joining us for today's webinar, Psychedelic-Assisted Therapy for Mental Health Explained, How Therapists and Patients Work Together. My name is Jolie Busby, and I'm the Education and Training Manager at ADAA. Dr. Jill Emanuel is founder and executive director of Urban Yin Psychology, PLLC, based in New York City. She previously served as Vice President, Clinical Training and Senior Psychologist at the Child Mind Institute. She has a breadth of experience in the evaluation and treatment of children, adolescents, young adults, and adults with mood disorders, as well as the spectrum of psychiatric disorders with a special focus on complex presentations. Dr. Emanuel has significant expertise in evidence-based treatments, including cognitive behavioral therapy, dialectical behavior therapy, radically open DBT, family therapy, and mindfulness training. She has extensive experience in supervising clinicians and trainees in multiple disciplines and has served in multiple administrative leadership roles. She also has significant experience developing clinical training programs that serve youth. As clinical psychologist in the state of Maryland, he completed his psychology training at Princeton University, the University of California, Los Angeles, and Otto Friedrich University, Bamberg. He is the owner of Psych Forward CBT, a Baltimore-based psychology group practice specializing in cognitive behavioral therapy for anxiety disorders, OCD, and depression, as well as psychological assessments for the workplace. Dr. Scatino also serves as a research psychologist at Johns Hopkins University for psychedelics and consciousness research. There, he provides clinical consultation on psychedelic clinical trials, guides participants during psychedelic experiences, and studies the efficacy of psychedelics in the treatment of OCD, as well as the role of provider in psychedelic treatment modalities. Thank you both very much for being with us today. Dr. Emanuel, I'm going to turn the presentation over to you now.
Great. Thank you so much, Julie. And thank you to ADA for having Dr. Scatino and I. We're very excited to be here today to discuss with you this very important, interesting topic. The way we're going to do this today is I'm going to serve as the moderator with Dr. Scatino, who's actually the content expert. So we're going to start right by me just turning it over to him so he can get us into it and get a little background on what we're going to be talking about today. And then we'll be talking to each other, followed by some time at the end for question and answer. So Dr. Scatino, take it away.
Great. And thank you, Jolie and Jill, for the introductions and getting us started. Looking for the slides. Okay, excellent. So I'm going to go through the slides pretty quickly. And the goal here is to just kind of set the stage for what we're going to be discussing today. We're really going to be focusing on the patient therapist or the participant therapist relationship in psychedelic assisted therapy. But before we do that, I want to talk about what are psychedelics anyway, right? So my first slide, we're going to talk a bit about, what are psychedelics? So a lot of people, when they say psychedelics, it might mean very different things. Fundamentally, psychedelics are a subclass of hallucinogenic drugs that cause shifts in perception and states of consciousness, primarily by activating the serotonin 5-HT2A receptors. So sometimes when people talk about psychedelics, they're talking about these things called oneirogens. Like ibogaine is an example of an oneirogen. It's basically a drug that causes a extended dreamlike state. There's also dissociative hallucinogens. Sometimes people refer to these as psychedelics as well. Those could be things like ketamine or DXM. Of course, ketamine is used as an anesthetic. DXM, you may know from Robitussin. It's an active ingredient in cough syrup, actually, but it's also a dissociative hallucinogen at high doses. And then there's entactogens, the most famous of which are the one we've probably all heard of is MDMA. Also, sometimes people refer to that as a psychedelic. For the purposes of this conversation, though, I'm going to be focusing specifically on the classic psychedelics. So those are the psychedelics in the bottom right corner of your screen. And those include psilocybin, LSD, DMT, and mescaline. And I'm also kind of an avid gardener, and when I hear about these substances, I like to find out where do they come from in nature. So, of course, psilocybin comes from mushrooms. There's a variety of species of mushrooms that produce psilocin, which is the active ingredient in psilocybin. And then things like DMT or 5-MeO-DMT actually come from excretions from a toad. So there's a lot of different natural sources of these substances out there. And in fact, the background of this slide has a picture of one of the natural sources of one of the classic psychedelics. If we were live in person, I would ask someone to shout out the answer, but there is a chat. So if you know which psychedelic has a natural source in the background of this slide, go ahead and just put that in the chat. Oh, somebody already got it. Great, thank you. Awesome. It is peyote. It's a peyote cactus back there, and it is the natural source of mescaline. Let's go ahead and go to the next slide, Jill. So we're actually going to skip this one. We may refer back to it later, but we'll start with this one. So I wanted to talk about the common features of psychedelic treatment, and I want to differentiate psychedelic treatment from psychedelic-assisted therapy. So we're going to be talking mostly about psychedelic-assisted therapy, but I want to talk a little bit about psychedelic treatment overall before we get into that. So there are some common, I would say almost universal features of psychedelic treatment, at least in the conventional, like experimental sense. The first commonality is there's a course of treatment that consists of 1 to 3 doses of a psychedelic substance. So this is not like a maintenance treatment. It's not something that goes on forever. It's 1 to 3 doses in almost all experimental studies on psychedelics. The second common feature is that the dose is a high dose. So some people may have heard of microdosing and things like that. That is not where the action is with respect to research into the therapeutics of psychedelics. It's high dose psychedelics. That usually means something like greater than or equal to 20 milligrams of psilocin, greater than 0.2 milligrams per kilogram of DMT, and greater than 30 micrograms of LSD. There's also this thing called a psycholytic dose. It's kind of intermediate between a microdose and a psychedelic dose, with the psychedelic dose being quite high and the psycholytic dose being like a low dose, usually below 10 milligrams of psilocin, let's say. And the idea there is that you can still have a conversation with somebody. You could theoretically do active talk therapy while somebody's on a psycholytic dose, but while somebody's on a psychedelic high dose, you're not really doing active psychotherapy while they're experiencing acute effects, at least as we understand active talk psychotherapy. Third feature is that the psychedelic substance, is administered in person at a providing healthcare facility or office. The safety and efficacy of self-administration of psychedelics or telemedicine administration has not been studied at all and is not recommended. So I won't be talking about anything that's doing that or anyone that's doing that. All the conventional research is done in person at providing healthcare facilities. Last common point is that the psychedelic is administered in conjunction with a supportive psychosocial intervention. This combination of the psychedelic substance and the supportive psychosocial intervention is what is referred to commonly as psychedelic-assisted therapy. And that's what we're going to be talking about today, mostly is that combination. So I just wanted to set the stage for that discussion. You can move over to the next slide, Jill.
Right here?
Yes, perfect. So there's some fun thought bubbles here. I had an animation that was going to go, but unfortunately that's not working today. But the bubbles contain the objectives for today's conversation. So there's really 4 core points that we're hoping to get to, and that we're hoping that you'll be able to learn from over the course of this talk today. So the first point is the therapist's role. What do therapists do before, during, and after psychedelic sessions? Next point is the big picture, current therapy options, and what's coming in the next few years. Third, the patient's role, how patients prepare, participate, and follow up in psychedelic-assisted therapy. And then what to look for, skills, training, qualities to make a strong psychedelic therapist. Also, interestingly, the background here is one of the session rooms that we had at Johns Hopkins University Center for Psychedelics and Consciousness Research. So as we're having our discussion today, I may want Jill to kind of backtrack to the slide so I can show you as we're talking about some of the topics that we'll be talking about today.
Okay, great.
Okay.
So should we leave it on this slide, do you think, for now, or?
You know what? Yeah, let's go ahead and leave it on the slide, unless there's another fun slide you want to leave it on. But
okay, yeah, I mean,
we could pretend we're in the session room.
I'm loving the couch and the whole thing here. So
let's do it. I like that. Yeah.
All right. So, I think that there's a lot of different places we can go today in having this conversation. And I know that there's a great interest in this topic. I think we have people I see all over the country. I see someone on here from Kazakhstan. So clearly there's definitely interest globally and across the US. So I think one of the questions that people often have is, if we're thinking about treating it for mental health, what are the kind of mental health problems that psychedelics are actually being used for at this point or being studied?
Okay, so one thing, I just want to kind of introduce today's discussion with this caveat that in the Western world, in almost every country, there's still no approval for therapeutic use of psychedelics, right? That in many countries, including the US, psychedelics are sort of a classified drug in which there's a belief that there's no known medical use for psychedelics. So much of what we're talking about is clinical research into the therapeutic safety and efficacy of psychedelics. There are a couple of exceptions to what I just said, but we'll probably get into those a bit later. What the research is showing us so far, and this is, some of these studies are pretty preliminary, some of them are further along, but there's a great deal of research showing that psychedelics, the classic psychedelics, once again, are effective for treating major depressive disorder. At least that's what the research is indicating. Of course, we need to go to the phase 3 trials and see how those shake out before we can make that claim, more firmly. But so far, the research is looking promising for treating major depressive disorder, including treatment-resistant depression. Another area where the experimental studies are showing some promise is substance use disorders. So there's actually a couple of clinical trials looking at alcohol use disorder. There's a couple of clinical trials looking at smoking cessation or nicotine use disorder, and there's been some efficacy and certainly safety shown in those populations. Finally, there's been quite a bit of research on psychedelics, particularly psilocybin, in treating existential distress. So that just basically means anxiety or depression that's caused by having a life-threatening illness or being diagnosed with terminal disease. So those are really the three, I would say, top areas where psychedelics has shown safety and efficacy so far.
Okay. So, and it's great to hear that there's been some evidence that's coming through. And I think your point about it's not really widely available is also true. I know sometimes there's a few states in the US, for example, where the psilocybin, I think maybe one, I'm not sure, you tell me, but where it's actually legal to purchase. But this is a different kind of thing that we're talking about here in terms of it being applied for medical use.
Yeah, that's correct. That's an important distinction, Jill. Yeah, there's certainly states in the US where it's decriminalized or legal for purchase recreationally. I think it's typically decriminalized, though, in much of the US. There are states like Oregon and Colorado that I think have the most permissive laws with respect to psychedelics, but even there, it's not approved for therapeutic use yet.
Okay. So what we really want to do today is we really want to talk about the therapy component and really talk about what it would be like for you as a person to participate in having this kind of treatment. And again, there's no one way to do it, and we'll be talking about that. But I think one question I have right off the top is, people are used to talking about therapy. You go in a room, you talk to a therapist. There's different kinds of ways to do it. People often refer to it as talk therapy. We talk more about different kinds of therapy like CBT, but what I would imagine psychedelic-assisted therapy is possibly different. Can you tell us a little bit about the different modalities of psychedelic-assisted therapy and how it might be different from talk therapy?
Yeah, I think it's good to say modalities because there's different types of psychedelic-assisted therapy, right?
Yeah.
There is not a one-size-fits-all with respect to psychedelic-assisted therapy. In fact, there's probably as many different ways to do it as there's different modalities in regular talk therapy. What I will say, though, is that there's typically in psychedelic-assisted therapy, there's 3 phases of it. So there's a preparatory phase, what we call PrEP, where we're getting the participant ready to have a psychedelic experience. And in that phase, it's almost like, think about it like an extended intake session. You're meeting a therapist for the first time, and they're taking your history. It's a little bit like that. We're gathering information about your mental health history, your social history, just trying to get to know you a bit better. And at the same time, we're also trying to prepare you for the experience. So we're giving you a little bit of psychoeducation about what to expect when you take the psychedelic. So that's the PrEP phase. The middle phase is drug administration or dosing phase. So that's when we actually administer the psychedelic substance in that high dose that we talked about. And really during that phase, with the classic psychedelics, the experience tends to be an inward experience. You know, the guides or the therapists in that experience are really trying to ensure safety and comfort of the person while they're having their psychedelic experience. This is not a time for active psychotherapy typically. Um, then there's the integration phase, and that's sort of the last phase. And integration it can mean a lot of different things depending on, who's doing the psychedelic assisted therapy. But generally there's two things going on. One is a safety evaluation. We're evaluating this person for safety. They've just taken a high dose of psychedelics. We're usually meeting them like next day after that. And we want to make sure that they're psychologically, physically safe. The second component is, and this is not in all psychedelic assisted psychotherapies, but there's like a meaning making component, right? Where we're kind of, assessing what meaning this participant has maybe developed or what insights have they gained as a result of their experience. And, we're kind of working with them in a process and helping them kind of develop meaning. It's usually participant led. Like the therapist doesn't usually go in. I'm using usually because there's always differences, but the therapist doesn't usually have an agenda. It is more participant led in the integration session. The other component, and this is for those types of psychedelic assisted therapies that are more active, there may be active therapy in this component. So like, let's say that the psychedelic assisted therapy is intended to be more of like a cognitive behavioral approach, right? They're kind of implementing CBT in conjunction with a psychedelic. You'll probably see in that integration phase a more active cognitive behavioral approach where you might be using tools or practicing tools as part of the integration phase.
Okay, that's helpful. And I'm gonna revisit some of those phases because there's a lot more questions we can definitely offer in that. I'm curious, and just off the top of your head, if you happen to think of something, would a typical, people have gone to the therapist before and really, we asked a lot of questions in the beginning. I'm curious, are there particular questions that you might ask in an intake for psychedelic assisted therapy that you wouldn't necessarily ask in talk therapy or CBT therapy?
That's a good question. So I try to be pretty broad-based in my questions when I do a typical intake, but whereas I might only ask like one question about religiosity and spirituality, I might ask more questions about spirituality, religiosity, metaphysical beliefs when I'm doing a psychedelic assisted therapy. And the reason for that is because there's quite a bit of research, a lot of it coming out of Johns Hopkins, that shows that psychedelics have the potential to kind of occasion these mystical type experiences for people, which have potentially have a spiritual component. So it's helpful as the guide or the therapist to get a sense of like what might come up for this person when they're having their experience. So I might emphasize that a bit more than I would in like a typical talk therapy intake session, let's say.
That makes a lot of sense, actually. Okay. So I would imagine that, people who are participating in this webinar might have an interest in doing this in the future, want to learn more. One of the questions someone might ask themselves is, am I an ideal candidate for this versus someone who may not be an ideal candidate? And I'm curious, what makes a person eligible and what would be a consideration to not do it?
Mm-hmm. So it might be better to start with what would be a consideration to not do it or exclusion criteria. Yeah. So I'll start there. Pretty much, I'm not gonna say all the research, but a lot of research that's been done contemporarily on psychedelics looks at excluding the following people. So people who have a history of psychotic disorder, things like schizophrenia, people have a history of bipolar or mania, typically excluded from studies. Also, people who have a first-degree relative with a history of those conditions are typically excluded. So I just want to make that clear that I'm not saying that psychedelics don't work for those people or not safe for those people. It's just not studied as being safe or effective for those populations because people with those conditions or histories are almost always excluded from the studies. So I can't really speak to that from an empirical standpoint. In addition to that, people that are children, minors, we don't do psychedelic assisted therapy with minors. The research has been on adults, so 18 plus. Historically, really up until the past couple of years, the upper age range was 65. So we would exclude people who are older than 65 for psychedelic trials. I think a lot of that had to do with kind of concerns about higher likelihood of cardiovascular illness in that population, and so they excluded folks who are older. But over the past couple of years, there's actually been studies that have increased that upper age limit. I believe it's up to 75 now. I'm not entirely sure about that. People are pregnant or could be pregnant, also not good candidates for psychedelics. People with a history of, cardiovascular disease, also typically excluded as well.
Okay.
So those would be the kind of not a good candidate currently, given what we know about the safety and efficacy of psychedelics. So if you're not in one of those categories, you're probably a decent candidate, probably a good candidate for psychedelics, with the caveat, of course, that they're not authorized for therapeutic use in much of the West at this point.
Right. And I think it's important to highlight that research always has to be more stringent with its criteria in order to make sure that safety is ensured. And so that doesn't mean that in the future, some of the categories that you or people that you said couldn't do it might not be able to do it because they might. It's just studies have to be tight to make sure.
Exactly.
Okay. It's really helpful. All right. So I think one of the things we're going to be talking about a lot is the relationship in between the patient and the therapist over the course of treatment. And, I'm curious, especially you doing this work, what tell us about the relationship between the therapist and patient. Is it different than CBT or doing that kind of therapy? What are the similarities and what are the differences?
Yeah. So, let's say that you're doing kind of the most bare bones, psychedelic assisted therapy, where it's really just about ensuring safety, right, and comfort for the individual while they're having the experience. In that case, the relationship's going to look pretty different than it would look in typical talk therapy. There wouldn't be a therapeutic alliance per se. There'd be a rapport, right? Of course, you want to get along with the person who's guiding you through your experience, but there wouldn't be a therapeutic alliance in the classically defined sense of, we're kind of working together on, collaborating on goals that are agreed upon by the therapist and the participant or the client, right? So in a rapport model, it's really, okay, I want you to be able to trust me enough and be open with me enough that you can share with me about your experience. And we're not really collaborating on goals per se. The goal is to administer the psychedelic in a safe and comfortable way. So there isn't that collaborative element, whereas in typical therapy, you'll meet with your client, and the therapist will discuss what the goals are and work on arriving at those goals and agreeing on tactics, techniques, interventions to achieve those goals. So it's a little bit different. But in psychedelic assisted therapy, where there is more of a therapy model, right? You're actually applying ACT or CBT or some other type of therapy in conjunction with the psychedelic. It looks almost exactly the same.
Interesting.
As it would without the psychedelic.
Wow, I didn't know that. Okay, that's I know there's some protocols that have the CBT in it. And for those of you, we're assuming you guys all know what cognitive behavioral therapy is, but just to be clear, it's a kind of therapy that involves focusing on thoughts, feelings, and behaviors in the present to achieve goals and make, skillful changes that way. Sidebar done. Okay.
Thanks for doing that, Jill. I appreciate it.
So, all right. So then I guess let's start talking a little bit about, there's a therapist and there's a patient or a client, go either way. So what typically is the role and the expectation of the client in participating in this treatment?
Okay. So there's a couple things that are important here. I think that with respect to the client's role, the goal is really to be as open as possible with your guide or your therapist. And I like to use a bit of a metaphor for this. So imagine that, the client's mind is a national park with, infinite numbers of trails and, a lot of different natural landmarks. What happens with the psychedelic essentially is that the psychedelic picks a trail to go down. And that might not be a trail that was even there before, or might have been a trail that the client has never traveled. So we're not going to know exactly what's going to happen on the trip, but it's important to know what we could expect to happen on the trip, right? Are we going to Denali National Park up in Alaska, where there's mountains and snow and glaciers, or are we going to the Grand Canyon, where there's a canyon, there's desert conditions, it's hot, right? So the more we know about what we could expect when we're going to this national park of your mind, the more effective we can be as guides and therapists. Because we can basically say, oh, you told us about that canyon there. Okay, now you're experiencing that. Okay, that's in context for me now as your therapist. Whereas if we didn't have that discussion, if we didn't do the prep work, I'd have a really hard time knowing maybe what you're bringing up as you're kind of going through your session. So I would say, like, first and foremost, being open about your history, about your psychology, about set and setting. I don't know if we're going to get into that later. Okay. should I hold back on talking about what that is?
If you want to do it now, go right ahead.
Okay, so I'll talk a bit about that. So in the psychedelic space, we've been talking about set and setting probably since research was done, in the original phase of research back in the 50s and 60s. So set really is just short for mindset. So it's your mindset going into the experience. Are you anxious? Are you stressed? Are you calm? Did you just have a relaxing week, or did you just have a very stressful week at work? The next day, are you going to be really busy with a lot of things, or do you have time to relax and reflect, right? So that's part of your mindset going into the experience. The other thing is setting. So, setting is really the physical setting that you're in, but it can also be the social setting as well, right? So physical setting might be that office I just showed you in the slide earlier today, where there's the couch and it's comfortable and it looks like a living room. But it could also be a social setting, like, we exist in industrialized Western society, so the setting that you have is going to be different than somebody who would have taken psychedelics 1,000 years ago or something like that. Right. So it's important to think about setting in a kind of more global or holistic way rather than just the physical setting that you're in. Okay. So can we control the setting? To some degree, no. Can we control mindset? There may be a little bit of opportunity to influence mindset, right? We wouldn't maybe set up like a really stressful event to happen just before you're taking your dose, let's say, if we can control that.
Okay. So what I'm hearing you say is that it is important for the client to be able to be prepared and ready for the treatment, and to really, and that set and setting, the therapist helps with that, and really the whole treatment is going to help with that. But the mindset of the person is really important. And the other thing I heard you say was, when you're on the trip, you may want to go to the Grand Canyon, but you might want up in Denali, and it may be better to just go to Denali. Like don't exist, just go to Denali and see what's there. And you can go to the Grand Canyon another time, right? Like, so it's very important to follow the lead of where the medicine takes you. Is that fair to say?
Yeah, I would say it is important to follow the lead of the psychedelic, right? The psychedelic is going to, it's okay if we're kind of mixing up the metaphor a little bit, but it's okay if the psychedelic takes you where it takes you. Ideally, your role as the participant or client is to let the psychedelic take you where it takes you. So like what Jill was saying, if you're like, you had your heart set on the Grand Canyon, but the psychedelic's like, no, we're going to go to the Denali part of your mind. You're going to Denali, and the best thing to do is to let that happen and not to resist that. Resistance of that can affect the mindset, right? It's better to allow the experience to take place. So we actually use this kind of aphorism or affirmation, mix up the word, but trust, let go, be open, right? So try to trust the experience, try to let go, so don't try to control the narrative, even if the psychedelic is giving you something that you don't necessarily want, and try to be open to that, whatever might come up during your experience. And that's really the best thing that one could do as a participant or client.
And then one of the things that might be helpful for people, how long does the experience last? Like, how long are they in there for?
So it depends on the classic psychedelic, but if we're talking about psilocybin, we're talking about a 6-hour experience. If we're talking about LSD, it could be 8 hours or more. And if we're talking about DMT, it could be an hour or less.
Wow.
So some people think about DMT as kind of the business person's trip because you're in and out so quick. You could have had your DMT and be out of the subjective effects, if you took it at the beginning of this webinar, and at the end you'd be done.
Right. Although we want people to create space for reflection and preparation and all that stuff too. So
Sure. So yeah, if we're talking about just the acute experience, so we're talking about that middle phase, like the drug administration phase.
yeah.
Like for DMT, it's an hour or less.
Okay. All right. So there's some questions I'm already seeing that are surrounding this, but we can go back to these questions because there's always, it's hard to convey, it seems like, what the actual experience will be unless you've done it, right? So we'll go back to that a little bit. I'm curious, for the therapist, what is really you've talked a little bit about it already, but what is the role of the therapist before, during, and after the sessions? What are you doing? Before, it sounds like you're asking questions and doing a proper evaluation of the person. What do you do during, and what do you do after?
Okay, yeah. So you got the before right. Yeah, that's what we're doing. Proper evaluation, getting to know the participant, getting them prepared for the experience. So kind of that informed consent stuff. This is what you might experience when taking a psychedelic, those sort of things. During the experience, really the goal of the therapist is to let the experience happen. So we tell the participants, trust, let go, be open. We try to trust, let go, and be open to what the participant's experiencing as well. We're not really trying to do any type of psychotherapy during the drug administration phase. As I was saying earlier, the psychedelic is intended to be an inward directed experience. You're focusing on what your mind is bringing up, what it's giving you. We really try not to engage the participant in conversations during that time. We let the psychedelic go where it goes with them. We will check in to ensure that their safety, that they're comfortable. If they need to go to the bathroom or something like that, we'll check in. We also have a blood pressure monitor as well, so we're monitoring blood pressure throughout the experience because psilocybin can increase heart rate and blood pressure. So we're monitoring those things. So we are kind of checking in, but we're doing as little as possible because we don't really want to distract from the participant's experience with the psychedelic. So that's the drug administration phase, and the integration phase, which comes the day after drug administration. Like I was saying earlier, that can take a lot of different forms. I mean, it could just be a really brief safety check, like, okay, are you experiencing any manic symptoms or psychotic symptoms or any other concerning, symptoms like suicidality or anything like that. So we're doing a safety check. We're looking for adverse events, which is typical practice in clinical trials, whether it's psychedelics or anything else. We're going to be asking these questions. That's minimal, but it could go into full-on therapy, right? We could be engaging the participant or client in a discussion about their experience. We could be looking for insights in that experience that might tie on to some of the mechanisms that we think therapies like cognitive behavioral therapy work, right? So if somebody had an insight about thoughts are just thoughts and they don't necessarily mean they're not necessarily facts, or they don't necessarily predict the future. Okay, as a CBT therapist or cognitive behavioral therapist, you might run with that insight, and take that and kind of incorporate that into the integration phase. So that integration can look a lot like therapy, as I was saying earlier, but it could also really just be a safety check. We're looking for adverse events.
Okay, that's really helpful. And into integration, do people ever have, I'm imagining people sometimes do have maybe life-altering thoughts or experiences or spiritual experiences. I'm curious how often you see that.
Yeah, so that's pretty frequent. I wouldn't say everybody has that. And in fact, I wouldn't say everybody has any type of experience with psychedelics. It's quite variable. But I would say around 25%, I think. You can look at this. There's studies on this. Maybe more will have a spiritual or mystical experience with a high dose.
Okay. All right, that's really helpful to understand. So it's like, not like you said, everybody's journey in this is pretty unique, and you see different things every single time. So that's helpful to understand. Okay.
Yeah, and I would add too, Jill, it's not just everybody's journey is unique. an individual's journey is unique from journey to journey.
Wow.
Okay,
Interesting.
so yeah, so you could have, and typically in our studies we'll do 2 doses. And that first dose might look nothing like the second dose, for that participant. So yeah, it doesn't just vary from person to person, it varies within the person and their experiences.
So it's very important then that the person, as part of preparing and even being a part of this, understand that maybe leaving expectations behind is actually really important.
100%.
Okay.
100%. That'd be like the biggest piece of advice I can give somebody who is having a psychedelic experience. The best thing to do is leave the expectations behind and be open to whatever the psychedelic might bring, whether that's pleasant feelings and thoughts and memories or images, or unpleasant feelings, thoughts, memories, images.
I think that lends itself well to my next question, which, this is, for some people, this is a very familiar experience, and people have tried different things or, and even maybe done research and participated in it, but others on this call may never have done anything in this realm and may be wondering, how safe is this? What is this, like, really, does this work? There's a lot of different questions that can come up. And so I'm curious about, what are some of the side effects that you might see, or a person might have from participating in this experience?
Okay, so the safety profile for psychedelics is pretty high, actually, which means it's a generally well-tolerated, safe drug at the doses that we administer at in the studies. But there are, just like any other drug, there are side effects. So some of the side effects that are most common to show up are things like dizziness, nausea, headaches, increase in heart rate, increase in blood pressure. All of those side effects tend to resolve, by the end of the acute experience. So with psilocybin, after the 6-hour experience is over, those tend to resolve, or within the day of taking the psychedelic, those resolve. So these are very short, side effects or adverse events that happen, but they're quite common to see headaches or nausea feelings or things like that. Some people worry about throwing up. That's very uncommon to see that. The nausea feeling might be common, but actually vomiting is very uncommon to see. There are some concerns out there about kind of more serious adverse events, right? So, a more serious adverse event might be something like something that's life-threatening, let's say, or something that leads to actual death. In healthy participants, we have not seen that ever. And there's actually a recent study that came out, I think in 2024. It's Hinkle et al. I could probably put that in the chat later. But they did a meta-analysis on hundreds of different psychedelic studies. And when the studies were looking at healthy volunteers, I think there's a total of something like 1,500 participants across these different studies. Healthy volunteers, that means people that didn't have a diagnosable psychiatric condition taking a psychedelic, never experienced any of the kind of serious adverse events. So what might that be? Things like completed suicide, enduring psychotic disorder, like so somebody actually developing psychotic disorder as a result of the psychedelic experience, or somebody developing mania or bipolar disorder as a result of the psychedelic experience. We actually haven't seen that. Another kind of thing that we've heard about in the recreational literature that people develop is this kind of like hallucinogen persisting perception disorder, where you basically continue to have these hallucinations long after taking the psychedelic, or you have these flashbacks to the experience. Once again, in healthy volunteers, have not seen that at all. So very, very unlikely to have that. Now, with people who have psychiatric diagnosis who participate in the studies, let's say we're working with people with a history of treatment-resistant depression, the percentages are 4% or less to have, adverse events that are more serious. It's important to note, though, with that in these populations, like treatment-resistant depression, that, if this population was in any study, you're going to see some degree of serious adverse events, right? People with treatment-resistant depression do, unfortunately, complete suicide on occasion, right? So what we found is that psychedelics don't increase that risk relative to that population in another study, let's say.
Okay.
So if let's say you're doing a study on like an SSRI for depression, we wouldn't see increased risk of serious adverse events with psychedelics versus a typical SSRI.
So the safety profile then is actually, at least in the long term and short term too, it's pretty good actually.
It's actually very good. Yeah,
Yeah,
for the classic psychedelics, I want to be clear, like I'm not talking about the other substances people refer to as psychedelics, but for classic psychedelics like LSD, DMT, psilocybin, yeah, very good safety profile so far.
That's great to see. So what are the benefits? What do people get out of this? What do you see happening?
So what we see, and I'll talk about treatment-resistant depression or major depressive disorder more generally. We're tending to see in the studies that psilocybin performs as well, or maybe even potentially better than typical SSRIs. Okay, now once again, we haven't completed a phase 3 trial, so these are more preliminary data. There is a phase 3 clinical trial going on now for psilocybin and depression, but the full results of that study have not been released yet. So, but the preliminary data shows that there's a comparable, effect with psilocybin. Crucially, though, and this is an important distinction, with an SSRI, that's a maintenance medication, right? You're taking that, daily, right? With psychedelics, we're talking about 1 to 3 doses, and we're seeing enduring effects out to 6 months. There was actually recently a study that was just published. I think it was Al Davis' lab at Ohio State University. 5 years they're looking out, and they're still seeing. And once again, just the 1 to 3 doses. They're seeing 5 years out that there's effect. So there's a lot of data kind of pointing to this idea that the psychedelics may initiate some type of sort of a catalyst for change for people that goes long beyond the acute effects of the substance have worn off.
Yes, I think that's a really important point, because one of the things I saw someone was asking about, it's not, you already clarified this, but it's not the type of thing where you do the medicine and you have the trip and then like it lasts for a few days and then it's done. What you're saying is that there is enduring effects that people have. And one of the things that can come out of doing this kind of work is that there can be a mind shift that allows for a person to actually initiate change in their lives, which is such a hard thing for people in therapy to do. Changing is hard. So what you're saying is the medicine allows for a person to perhaps have more bandwidth and will to be able to do so. Is that what I'm hearing?
That's what seems to be going on, right? Because the acute effects of the substance are, they wear off within 6 to 10 hours depending on or 1 to 10 hours depending on the substance we're talking about. But we're seeing these effects endure 6 months, 1 year, 5 years out. It's suggestive of there's something shifting that's enabling change in a more enduring way. So the psychedelic may be serving as a catalyst for change. We're still research needs to be done to identify mechanisms of change and things like that, but that's what seems to be going on just based on the enduring nature of these effects.
Yeah, I think, okay, that's really helpful. Jonathan, there's a lot of questions in the chat.
Okay.
So
I'm seeing them pop up as I'm talking.
I'm going to ask you one more question, and then while you're doing that, I'm going to scan and start looking for questions because I want to make sure we get to that. But what if a person wants to pursue this kind of treatment even in a clinical trial? Obviously knowing a place like Hopkins that has the reputation is really, really helpful. But what kind of skills, trainings, and qualities make a strong psychedelic therapist? What does the person look for?
Yeah, so this would be a great question to ask after the FDA, if they ever do approve psychedelics for clinical treatment. And of course, we'll see whether the data support approval. We're still gathering those data to see if that's the case. But at the present time, what I'd say is this: you want somebody that has, I think, good therapeutic skills. This may be a bit of a dodge, but just someone who's a good therapist, someone who's a good listener, someone who's empathic, someone who's non-judgmental, someone who can create that space for you to be open, to trust, and to let go. You're looking for that person. There are certificate programs. There's a variety of different certificate programs for like psychedelic therapists. You know, it's hard to say, you know, whether and how much those matter, because we still don't know if psychedelics will be approved for therapeutic use, and if they are, what the format's going to be, right? Is it going to be just psychiatrists who are able to prescribe? Can therapists do it? Is there some other format, or is there multiple formats? So having a certificate that kind of certifies you in psychedelic assisted therapy might be a little bit premature, since we don't know like actually what that's going to look like from a regulatory and legal standpoint.
Right.
But I will say that they're out there. There are these you know, schools or institutes that do certify people for therapy. But I would just say, generally speaking, you're looking for a good therapist that can help you to feel comfortable and open with sharing about yourself.
Wonderful. Okay. So I'm going to start getting into the questions. And some of the, I'm going to do my best. We're not going to be able to answer all of these, and some we've kind of answered already. So I bear with me here. But one of the things that I've seen a couple of people ask is it a requirement for therapists who have participated in psychedelic assisted therapy themselves, do it themselves prior to guiding clients?
Yeah, so that's a bit of a, I don't want to say controversy in the field, but there's a topic of interest in the field about whether a guide or a therapist should have had their own personal experience with psychedelics prior to administering psychedelics as part of psychedelic assisted therapy. Here's the thing, I mean, like, because it's illegal, you know, nobody can require that, right? So if I'm at Hopkins, you know, my supervisor or PI at Hopkins can't say, you know, you need to go out and get your own psychedelic experience before you, you know, you're a therapist on a study, because that would be basically an illegal directive for someone to give. So I can say generally that a lot of folks who are guides have had experiences, but it's not a requirement. And there are also guides that haven't had experience of their own.
Okay. All right. So it really varies.
It varies, yeah. And there's pros and cons to both, right? I mean, if you had experience of your own, you might be able to kind of know a little bit about the contours of that psychedelic experience, and you have your own personal, you know, framework for thinking about a psychedelic experience and the subjective effects that someone experiences. And at the same time, I mean, that might be a drawback, right? You might over kind of identify with your experience and expect that other people are going to have a similar experience with psychedelics, and they might not have a similar experience at all to what you had. It might be totally different than that, and you might be trying to fit your experience onto theirs. So I think just having humility is important. I think the trust, let go, be open thing is important too.
Okay.
Yeah.
There's a couple of questions people are asking about with regard to dissociative disorders. So depersonalization, derealization. Some people are asking about research on it. Has there been any research in that area? And I think I saw something else where someone was asking, is it, you know, can someone who what considerations are necessary if someone experiences those? Are they even permitted in the trial? So information you have in that area would be helpful.
Okay, yeah, that's a great question. It's one I'd ask, you know, if I was out in the audience. But there is research going on now, looking at conditions that tend to have or often have, you know, dissociative elements like depersonalization, derealization. The classic one is PTSD. Although that's not a required symptom of PTSD, it's a feature of PTSD for many people who experience that. As far as I know, and there's not a lot of studies looking at classic psychedelics on PTSD. We have one going on at Hopkins right now. We're not excluding people who have dissociative experiences. So if you've had that, you can still be included in the study.
Okay.
So yeah, it's not one of those things like history of schizophrenia that's kind of a automatic rule out.
Okay, that's helpful. And with regard to the, you know, we talked about the rule outs. Some people are mentioning, you know, what if you're on an antipsychotic medication or a mood stabilizer, but perhaps, you know, maybe it's not for bipolar disorder or psychosis. Is that a disqualifier, or could they still be in the trial?
That's an excellent question. My instinct is to say no, that wouldn't disqualify if you don't have a history of a psychotic disorder or a bipolar disorder. I'm not 100% sure about that though.
Okay.
Yeah.
One person, I think I actually saw a few people ask this, what, if you're a person who tends to be anxious or has an anxiety disorder, is there any increase of anxiety or panic during the experience? Is there any concern about that?
Yeah, so one of the things, and this is, I guess, like one of those, adverse events that could happen that's not serious or life-threatening is that one could have an increase in anxiety. That's pretty common. Psilocybin and the classic psychedelics can increase emotionality more generally. So some of the emotions that you may typically experience might be heightened or amplified during the psychedelic experience. So I would say yes, but I wouldn't say that people who have an anxiety disorder, let's say, are more prone to experiencing an increase in anxiety than someone with depressive disorder without an anxiety disorder. So it's not that people with like a strong history of anxiety are more likely to be very anxious under psychedelics compared to somebody who doesn't have a significant history of anxiety.
I'm going to continue to ask questions, but while I'm doing that, I'm going to move the slide to just so everyone's aware of some currently recruiting studies. There was a question about OCD in the chat, which I might be able to get to. There's another study that Jonathan's put up about chronic low back pain and depression. You can use the scan on your phone to get the QR code and get more information on these trials. So while we're talking about that, and Jonathan, I can certainly give you more time at the end to talk about this if you'd like.
Sure, yeah.
Okay, so one of the things that I think we could probably flush out a little bit more, and this person put it quite directly and helpfully, is what does an actual session look like? I mean, and like in terms of how can the patient decide whether or not to go ahead with this therapy? Like what if you could do like a 1 minute kind of take us through the experience that you go into the room and you lie down on the couch, like that kind of thing. If you could help us with that so we understand what it might look like.
100%. I think we have a slide for that, Jill.
We might actually. I can go back. Is this the one?
Let's go back to that slide. Okay, so let's just kind of walk through the experience. Okay, so we're at dosing day. We've probably met now anywhere from 1 to 4 different times for prep, and each of those times would have been about 90 minutes to 2 hours. So we have a bit of rapport going at this point, hopefully. And it's dosing day. So we walk into this room, a room that looks like this. You'll see the couch in the background. You'll see 2 chairs in the foreground. You will see a end table or nightstand with a lamp and a blood pressure machine on it. So what happens is you'll come into the room as the client or participant, and we'll have a brief discussion, just checking with you, see how you're doing. We're kind of looking at set and setting again, right? Particularly mindset coming in. We'll start early in the morning because it's a long experience, right? 6 hours for psilocybin, let's say. So we usually start around 8:39 with the dose. When you take the dose, you don't experience effects immediately. So there's still time to talk, to have a discussion. We will ask at this point for you to, we'll have headphones, and the headphones will play a playlist that lasts about 5 to 6 hours. Mostly instrumental music, not a lot of lyrics in the whole playlist. We have a blindfold, or eye shades rather, and we'll ask you to put the eye shades on. We'll ask you to put the headphones on when you're ready, and then to lie down on the couch and have your experience. Typically, it'll be about a half hour from like when the dose is taken to when the client or participant starts to experience those first effects. So there's still a lot of time to chat and talk if needed, but we do try to encourage the participant to get relaxed, get into the experience, lay down, and direct their attention inward to what the psychedelic might be giving them. That's kind of what happens. So they'll have the experience, they'll start to experience effects. The peak effects will typically be with psilocybin around like 2 hours to 3 hours in. And during that time, we'll check in with the participant. We'll check blood pressure like once every half hour or hour, depending on where we're at in their experience. Check in if they need to go to the bathroom, things like that. And then around like 5 hours, 5.5 hours, 6 hours in, they start to come out of the experience, and we'll be ready to, they need to go to the bathroom again, help them to do that. we ask them to pack a lunch. So we'll bring the food out and, they can eat. Water throughout, where we're offering water if they need that. So we're almost kind of like glorified like flight attendants, honestly, during the trip, because we're really there to kind of ensure comfort, as they're going through their experience. So that's kind of the typical experience. Sometimes it'll look like they're sleeping for 6 hours. They're not sleeping because the psychedelic actually kind of, almost prevents that from happening. I'm not sure of the neurobiology of that, but there's something about the drug that makes that difficult to do. But they'll look really calm and placid, and you might ask them after, like, "Hey, what were you experiencing?" And they'll tell you a story that, "Well, I went to this place, I was there, I was experiencing this, I saw that, I was really emotional," but like you might not even know everything that's necessarily going on unless you're checking in. So, which is why we do check in with the participant during their experience as well, just to see how they're doing in there.
So I think we have time for just one more question.
Yeah, and you got it. Absolutely. So I'm going to kind of double combine a question, but probably focus on the second half more, and because people can learn more in other ways. Some people are asking about how this compares to ketamine, because ketamine is being used actually, legally now. And more so, I think one question that's probably most applicable, which may be where the ketamine answer can come, is where can prospective patients learn in depth about psychedelic therapies? Where can people go for more information?
Okay, so I told you I was going to talk about ketamine, but here we are. We've got a question about ketamine.
There's a lot of questions.
Yeah, I know, I get it. It's something that is authorized for clinical use. How does it compare to ketamine? My understanding about ketamine, I'm not an expert in ketamine because, once again, I'm an expert in classic psychedelics and experiments with those substances. What I can say, though, briefly, is that ketamine seems to be something that does require more treatments. You go back for more treatments with ketamine. At least this is my understanding. Whereas psilocybin and the classic psychedelics, it really is intended to be this 1 to 3, treatments or 1 to 3 experiences with the psychedelic. I think that's a pretty significant difference. I would also say that the acute effects tend to last much longer with psilocybin or LSD than they would with ketamine.
Okay, and then where can people just go to learn more?
There's so many different places. I mean, I think that even the Johns Hopkins website, like the Center for Psychedelics and Consciousness Research, is a helpful website to peruse for information. There is an international research body. It's called the Open Foundation. They're based out of the Netherlands, and they put on a lot of different talks, in-person conferences, webinars, and I think they release a lot of just like kind of free information throughout the year. So I'd recommend getting connected with the Open Foundation if you can. It's a great way to learn more. That's in fact how I got into psychedelics, as I went to a conference that was hosted by the Open Foundation back in 2022. And since then I've been in the psychedelic space, and it's been great.
Great. Thank you so much.